Okay, so our next presenter before the panel conversation will be Hank Greely. He is a professor of law at Stanford University. He's also the director for the Center for Law and the Biosciences, one of the experts in bioethics. So please welcome Hank. Thank you.
One of my close relatives owes her life and her sanity to bioelectronics. She was diagnosed with geriatric depression, which then became geriatric depressive psychosis. She was committed. She was losing weight that, unlike me, she couldn't afford to lose. She lost 10% of her weight because one of her delusions was that she couldn't eat. She was in bad shape. We eventually convinced people to let her have ECT, electroconvulsive treatment, which is a form, I think, of bioelectronics. And within 6 treatments over 9 days, her sanity returned. It was the most amazing thing I've ever experienced to see someone who I had known for many, many years and see a stranger behind those eyes, completely convinced of untrue things. My wife, for example, was running a multi-billion-dollar Medicare fraud internationally, and all my travels to give talks and so on, those were in pursuit of that fraud, and we were about to be arrested. And one thing I learned is you can't talk delusional people out of their delusions. There are always explanations that they can come up with. So that got me interested, that increased my interest in bioelectronics. I have very cleverly several months ago when asked for a title for my talk today, given the most innocuous, flexible title of all, ethical, legal, and social something or another's in bioelectronics. But what I really want to talk about is the use of at least some forms of bioelectronics in mental health, with a focus on non-invasive neuromodulation devices, but some of this will also be relevant to what we've heard already today with the more invasive electrode implantation devices. I think this is an urgent need. Mental health is an enormous problem all over the world. I used to think that I didn't actually know very many people with mental illness. And then as I got older and wiser, not only have more people develop mental illness, but I realized that a lot of people who I just thought had been a little odd actually were mentally ill. You will all, if you're my age or older, you know what I'm talking about. Those of you who are younger may think that you don't have that many relatives and friends who have mental illness, but you're wrong. And you'll get wronger as you get older. And the really depressing thing about it is that the last 20 or 30 years have had almost no progress in treatments for mental illness. The pharmacological approaches seem to have stalled. But the brain is, at least in part, an electric organ. And there have been efforts to use electricity to treat mental illness. ECT goes back 60 years or longer, actually 80 years or longer. And a new generation looking to solve this, looking to make some progress on this really gripping, important ethical problem of how to deal with huge amounts of human suffering caused by mental illness, is turning almost in despair as much of anything as the other methods aren't helping to the possibilities of electronics. But we're not making much progress there either. And so what I want to talk about is some barriers that I think are keeping some of these methods from being developed and ultimately commercialized and available in the clinic. Now, one huge barrier at the very beginning is maybe none of them will work. The brain is really complicated, the science is really hard, and so maybe the biggest barrier is just can't get there from here. And I recognize that, but I think there's some other more specific things we can talk about and maybe even do something about to try to encourage the development of bioelectronic devices for treatment and prevention of mental illness. I'm going to talk about 5 things in particular, mental illness and neurological disease as well. 5 things in particular. I'm going to talk about problems with research, problems with commercialization, problems with payors, problems with doctors, and problems with patients in society. all with the main focus of non-invasive neuromodulation. A little backstory to that, too. For the last 7 or 8 years, I've been very interested in and following what's called transcranial direct current stimulation. Transcranial direct current stimulation is, as it sounds, putting direct current through your brain, through your cranium into your brain. It's had a vogue and lots of interesting papers, very provocative, very good results in the first set of papers. It does seem to be undergoing the classic science decay curve, the half-life, where the first papers are all up here, and then the next papers are like that, and that, and that, and that, and that. And maybe you stay above 0, and maybe you don't. So maybe it turns out that one of the problems with TDCS is that it just doesn't work. But I think it's a useful case study for some of the other problems with the field and moving into the clinic with new devices. So that's basically where I'm coming from. Let me start. Oh, this may not have been what you expected from a talk that had ethics in its title. Happily, there are at least 2 other people in the conference who will be talking, I think, about some of the more classic ethics questions and neuroethics questions raised by bioelectronics. Both Jason Robert and Aaron Klein will be talking about, I believe, some of the issues around consent, around control, around identity, some of the classic issues in ethics and neuroethics that get raised by these devices. I'm taking a more practical approach. Or I'm looking at more immediately practical questions. So first, research. Problems. Well, there's both too much and too little. There's too little research, particularly in the area of transcranial direct current stimulation, but also in other areas of non-invasive neurostimulation. There's too little basic research into what actually is happening. So, for example, we don't really know when you put an electrode here and run X milliamps at a certain voltage for a certain period of time, we don't know where that electricity is going. My colleague at Stanford, Gary Glover, has come up with a way to do TDCS inside an MRI machine, to do them simultaneously, and he's doing research to try to figure out where the current is moving, where neurons are being stimulated. But we don't really know that. We don't know how it works. Now, there are a lot of things in medicine where we don't really know how things work. I think Parkinson's, the ability to use deep brain stimulation to treat Parkinson's is a wonderful example. We thought we knew how it worked, and now 20 successful years later of its clinical use, we know that it works, at least for a while for most people, and we know that it doesn't work the way that we thought that it worked, but we still don't really know how it works. So you don't need to really know how it works, but it's helpful to have some understanding of the mechanism and how things go about, how things continue. But so there's too little basic research, I think, in how this works. The irony is I think there's almost too much applied research. Too many labs are doing too many things that produce too much data. Now, you might think, how could there be too much data? Well, at some point, too much data becomes noise. And when you've got people doing experiments with 2 electrodes, an anode and a cathode, putting them in different locations on the skull, different montages, using different voltages at different amperages, and aiming at different conditions or trying to enhance different traits, you end up with thousands of little findings, none of which are really particularly directly comparable. And it's being done, for the most part, at individual labs on R01s or other research grants or very small startup companies that don't have the resources to throw $100 million into a coordinated research program. And so you don't have anybody saying, well, wait, let's take this and exhaustively explore voltage issues and what voltages we should use, and exhaustively explore montage issues and what montage issues we should use, and exhaustively explore one particular indication or one particular use. So in a way, you get chaos and not progress. Second problem, commercialization. We have a well-established system that has its major minuses, but also its major pluses for developing pharmaceuticals. Between the biotech industry and the pharmaceutical industry, there is a well-understood pathway to raising lots of money in order to explore drug candidates, in going through the FDA, in going through payors, in getting your reimbursement, in getting your stock options cashed in, and becoming rich beyond your wildest dreams of avarice. At least so biotech startup people hope. We don't really have that in this area, or for that matter in medical devices very generally. The medical device market looks quite different. There are a couple of big players, Medtronic, Johnson & Johnson, and then depending on how you define medical devices, things like GE and Siemens and Philips for MRI machines, but for personal devices, it tends to be much smaller companies that don't have the clear pathway, that don't have a lot of money, that can't spend $500 million on a set of clinical trials. Part of that is because the FDA typically doesn't require $500 million worth of clinical trials in the device world. Although the more novel your device, the more likely you are to be required to do serious clinical trials instead of doing what's called the 510K system of saying, oh, I'm kind of like this one, and this one is approved, so that's good enough. But there isn't that sort of ecosystem that we see in pharmaceutical and biotech to allow pouring a vast amount of money into a particular device, into a particular exploration. And I think one of the reasons for that is actually a legal problem. Companies don't have as good protection for their products in the device space as they do in the pharmaceutical space. Patents on molecules are a lot more powerful than patents on devices because it's easier to invent around a particular patent device than it is to invent around a particular patented molecule. Once you've got, once the patent lays out the specifications of what your device does and how it does it, tweaking it in ways to try to get it around the patent is easier, I think, than trying to tweak molecules, especially since the patent office will let you include some of the tweaking of molecules in your original patent specifications. What that means is, one of the reasons maybe we're not investing, say, $300 million in trying to figure out a good non-invasive neuromodulation system to treat depression is that no one can count on being able to get $300 million back from it. In drugs and devices, there's a second level of protection beyond patents. The FDA has what it calls regulatory exclusivity. So if you come out with a new chemical entity that gets approved, you get 5 years during which FDA promises it's not going to license anybody else to sell that new chemical entity. Patents don't matter. The thing can be completely unpatentable. It could have been patentable once and the patent has expired. You get the first FDA approval for this new chemical entity, you get 5 years. There's also another provision, not quite as helpful in mental health, of the Orphan Drug Act. You come up with something that treats a condition that only affects 200,000 people or fewer in the United States in a year, and you get 7 years of strong protection. There's a bit of an orphan drug device provision, but it's not nearly as good. So I think we may have some commercialization problems that are caused by insufficient protection of the intellectual property in a way that decreases people's incentives to do the kind of serious, focused, expensive research that would be needed. Third problem is payors. The insurance companies and Medicare, Medicaid, and so on are used to drugs. They understand drugs. Drugs are easy. Devices, not so much. Now, we have a little bit of experience with this. There are a couple of devices for mental illness that have been FDA approved. Transcranial magnetic stimulation is one of them for treatment of depression. And it doesn't get used very much. ECT is another example. ECT actually predates the Federal Food, Drug, and Cosmetic Act. It's been around that long. It is an approved treatment. It's not easy to get it paid for. So the payors, getting them accustomed to a new kind of thing is going to be a problem. Of course, right now, I think one of the bigger problems for the payors is they don't want to pay for things that haven't been shown to be effective. And the bigger problem for the non-invasive neuromodulation devices is even when they've been FDA approved, such as TMS for depression, they're effective, but they're not very effective in a way that can lead payors to be reluctant. But payors, I think, are going to be a significant problem. And if you're thinking about, do I want to invest a lot of money in this field? That's something you'd worry about. A fourth problem is the physicians. Now, I'm married to a physician. retired physician. I'm very fond of physicians. Some of my best friends are physicians. I'd even let my children marry physicians if they wanted to. But how to say this? So probably what we call schizophrenia is going to turn out to be a set of symptoms that are actually 20 different underlying diseases, or more so. Psychiatry is a set of symptoms that probably involves 20 underlying diseases or more. Psychiatrists. Psychiatry is one of the strangest medical specialties I've seen. Now, I should be careful. Any psychiatrists in the room? Okay. Do you disagree?
Yes.
Okay. I am in Texas. Are you carrying?
Hell no.
Okay. Although you do have a right, apparently, in Texas. Psychiatry is in my experience at least, an unusually fractured medical field. There are still Freudians out there. There are many people using cognitive behavioral therapy, which has had some good results in some cases. There are people who are using drug therapy almost exclusively. Psychiatrists apply ECT, although it's a very small number of psychiatrists who do it. But other psychiatrists think ECT is barbaric. I once had a conversation with the head of the the president of the American Psychiatric Association, about offering to try to work to loosen some of the anti-ECT laws in very restrictive states like my home state of California. She wasn't interested at all. Didn't think it was particularly important, didn't think it was particularly useful. Psychiatry is not, I think, going to band together to say, yes, let's go for these sorts of devices, in part because of its own deep divisions in approaches to mental illness. So I think psychiatrists are going to be a problem with respect to this. But in some ways, I think the biggest problem is going to be patients and society. You say ECT, and people think of One Flew Over the Cuckoo's Nest. They think of shock treatment. They think of Frankenstein, that 200-year-old story, where, interestingly, Mary Shelley never tells us exactly what animates the monster. The word electricity is used at some point, but the great sparking machines and so on, that all comes in the movies and the plays. That comes later. But people associate Frankenstein through the movies with electricity. They associate monsters with electricity, and using electricity through your brain, even though your brain, to some extent, actually functions electrically, is very unsettling to many people. So the extent to which patients are willing to use electrical stimulation in the extreme ECT, but I think also these other much less serious, much less invasive methods, much less dramatic methods through non-invasive neuromodulation is going to be a constraint and a limitation on how the field develops. Much of what I've talked about, I think, will also be true in slightly different ways for invasive neuromodulation, implanting electrodes, although maybe not as much. And you know, I'm a law professor. The first thing I try to tell my first-year law students is the two words with which you should begin an answer to every legal question are, it depends. Because it always depends. So take something like the visual cortex stimulation that we heard about earlier today. That, I think, would probably be a very specialized device. It may not have the same kinds of intellectual property problems. It may have a big market. People are interested in overcoming their blindness. You're not going to have the public negative view of it that you would have with, say, electrical stimulation. Electrical modulation, because it may be stimulatory, or in some circumstances it may be repressive. So different settings will have different problems, but some of the problems, including, I think, particularly the commercialization problems, are going to be quite common. I think in order for us to make progress in treating a lot of brain conditions, we need to explore the possibilities of bioelectronics. But, and I will say the two words every audience most likes to hear from every speaker. In conclusion, bringing a successful treatment to the clinic involves a hell of a lot more than science. Translation is the great buzzword in medical schools everywhere and has been for about 10 years, and everything has to be translational and translate this and translate that. Translation turns out to be hard. I'm not sure universities are particularly set up to be good at it, because it involves not just coming up with something that scientifically works, but something that can get money in order to be developed, and something that can get through the FDA, and something that can get companies interested in investing it because they think they'll have a protected market that will allow them to get a return on their investment. And doctors who are willing to use it, and patients and payors who are willing to pay for it, and patients who are willing to accept it. All those are barriers with every kind of new medication, of new treatment. They're bigger in some areas than in others. And what I want to leave you with is my sense that bioelectronics holds great potential for dealing especially with brain diseases, that it is an area that desperately needs new approaches and new things to help pull in, help cash out that potential, but that there are special barriers, not just scientific barriers, but other barriers to which we need to pay attention. Thank you for your attention. And I actually unusually left time for questions.
Yes. And if you want to go ahead and ask your question, Rob.
So we have 324,000 people with cochlear implants, companies with combined market capitalization of $30 billion. And so why are you saying there's no clear path to commercialization? Yeah.
Well, certainly there are exceptions, and there are a couple of huge companies, Medtronics and the device part of J&J in particular. But there isn't the sort of ecosystem of startups licensing from universities, becoming biotech companies that then become successful enough and get either go public or get bought up by somebody. And with investments that are in the hundreds of millions of dollars. I don't think we see that in devices very much. Sure, there are a lot of successful devices out there and a lot of successful device companies. I think you see fewer of them in the brain space, though cochlear implants is a great counterexample. But I think that's,
it's the exception.
Yeah,
it's the
I think it's
exception.
more it's the exception, not the rule. I mean, there are areas, say stents, those are devices. The stent, there's a nice pipeline, pun for a cardiac device, not necessarily intended there in terms of pipeline. But there's a nice pipeline for stents, but not for a lot of other things. And not, I think, for this.
Psychiatric or neuropsychiatric medicine is a large parameter or polyparadigmatic space. I'm not at all clear that it's as cruel or invasive as oncology at times. Bernard Gluck doing regression ECTs in the 80s found most of the current travel down the carotids with bilateral ECT. And now my question, in the case example you presented at the beginning of your talk, for psychotic individuals or individuals who have anosognosia, lack of awareness that they have a problem, can they really, or did this person provide informed consent? Was there a specific informational competency hearing with a subsequent designated substitute decision maker?
So to your first point, it's what is unusual about psychiatry, I think, is certainly not its cruelty or anything bad about the motivations of the psychiatrists, and it's not nearly as painful or desperate as oncology or much of surgery. And what I think is, I like your phrase for it, polyparadigmatic. If I can wrap my tongue around that, I'm going to need to remember that. But it is, I think, compared to, say, oncology or pulmonology or rheumatology, there are more different paradigms in play in psychiatry, or one might even say at war in psychiatry, than in most places, which makes it harder for the field to present a unified position in many ways, which also decreases to some extent its political ability to lobby for changes that not only could help psychiatrists but could help their patients. So psychiatry is unusual. In terms of the ECT case, in California where this took place, the Landis-Short-Petras Act of 1972 passed really as part of a general reaction to One Flew Over the Cuckoo's Nest, but also to One Flew Over the Cuckoo's Nest, great movie, great book, written by Ken Kesey while he was at Stanford in a creative writing program. It's fiction, but there were plenty of non-fictional abuses of ECT, and particularly of lobotomy. People sort of blur together the lobotomy and the ECT in One Flew Over the Cuckoo's Nest. The end point is the lobotomy, it's not the ECT. But there were certainly plenty of abuses of ECT and other devices. California enacted very protective legislation that I think has ultimately become overprotective. And so yes, even though the literature is quite strong in saying that ECT will significantly help 80 to 85% of patients with refractory, particularly geriatric psychotic depression, depressive psychosis, which is enormously better than drug treatment or other treatments that we've got. The law does require, and we did go through specific consent, there has to be a non-treating physician. One of the non-treating physicians, a psychiatrist or neurologist, has to meet privately with the patient and certify that the patient does have the competency to make consent. And then there are consent meetings. The non-treating physician, I think, has to meet either once a month or once every 2 months to do that. The consent is much more common than that. There was a period when there was never a judicial hearing, but there was a judicial process that started at a representative of the judiciary was there to both make inquiries, and surrogates, including myself, were appointed. So yeah, it met the steps. I think in the California case, California, I think, has gone overboard because we're California and that's what we do. Also, the large population of very active and public Scientologists in California doesn't help with any California legislation that has anything to do with psychiatry, because Scientologists appear to be deeply allergic to psychiatry, and publicly so. So that one, as a lawyer who works in health law, I was satisfied with that the procedures were fulfilled. As somebody who's interested in health policy, and especially mental health policy, I thought the procedures actually were a little too stringent and probably kept some people who would benefit from it from being able to.